moving on, our topic is on prognostication or prognosis. And as you can see here, the Rodin thinker, he's thinking about it. And it reminds me of, I don't know why it reminds me of the thinker, but if anybody remembers Red Skeleton, who was a comedian, he would have a comedic skit where he would have somebody come up and try to rob him. That was the skit, and he was always notoriously frugal, and so the robber says, your money or your life. And the comedian turns to the camera and he says, I'll think about it. So anyways, next slide, please. So we want to focus on the 4 M's. For those familiar, those are the 4 M's. And we want to focus on what matters. And there's different elements of what matters that I hope to help you with, one of which is prognosis, or either that or life expectancy is another way to say it. But ultimately, what we want to do is, by understanding what an older adult's lifespan might be, and not that we always have a crystal ball, but it can help guide them, for their healthcare goals and outcomes. And these need to be created in relationship to their preferences. So when somebody says, I want everything possibly done, that is a different connotation and creates a different healthcare plan than somebody says, if nature's taken its course, just let it take its course. So we have to distinguish between, what people really want, and honor those preferences as best we can. I mean, sometimes there's nothing that we can do from the healthcare field, where any intervention would be futile. And so a lot of times, as a geriatrician like myself, would think about it in terms of, is this futile care, or is this going to achieve a better outcome? And that better outcome may be a cure, would be on one end of it. And the better outcome may also be palliation or being pain-free. So again, to comfort care versus curative care. And so a lot of times that's how we think. And that issue doesn't always come up with, both specialists and primary care providers, because they think, we're dealing with a symptom here, so let's deal with the symptom. They don't take the big picture. So that's why we want to focus on what matters, to sort of expand our understanding of what's important in terms of the patient's care. And then I also say that there's a potential for the older adult to defer to their family member. And if you do see that, then sometimes it may be an indicator of memory loss in the older adult. So if they turn to their parent or to their son or daughter and say, I don't know, ask them, when you ask them, what matters most to you? And they just turn and say, I don't know, ask them. That could be an indicator that there's Alzheimer's or some other dementing illness going on. Okay, so let's go to the next slide, please. So as we see with this lovely painting here of an old man, our goals are to understand why we want to know about prognosis and how that plays into the provider-patient shared decision-making process. We also want to report trajectories as to how people have an absolute lifespan that's preceded by a functional lifespan, where they lose function within a 2 to 3 year period prior to their death. And then we want to be able to have some comfort level in trying to provide an estimate of remaining life expectancy. So we'll walk you through those prognosticating tools. Next slide, please. So we have a 92-year-old male who arrives to clinic for surgical clearance entailing a left knee replacement. He looks younger than his stated age, and he's functionally independent, which is all good. He has, however, systolic heart failure and severe degenerative arthritis that he attributed to contact sports in college. The surgical risk calculator was used, and he has a 10% perioperative mortality rate. So the question is, how does this prognostic index influence the clinical conversation? So you have, firstly, so does anybody have a reaction to this? I mean, it could be, should this guy have surgery or not, or maybe caution. So does anybody have you can unmute yourself and just mention, or you can put in the chat box. So if you're the surgeon, would you do surgery on this patient? So you can put in the chat box, yes or no. Just pretend you're the surgeon. Okay, so we're getting some positive responses. Thank you for those. Yeah, so this guy is functionally independent. So really, it shouldn't be so much age, and it's more of the chronic disease that raises some concern. And so yeah, thanks, Crystal. That's really the key point, is that if the person understands the risk, and in fact, this individual did understand the risk and was very animate about moving forward. Now, the question is, though, and how much remaining years of life expectancy do you expect for a 92-year-old? And so the answer for that would be based upon tables of life expectancy. He would have, on average, about 4 more years of life expectancy. So that would pull him up to 96. So 95, 96 years of age. Yeah, so he probably, his quality of life potentially could be improved for a remaining 3 to 4 years. All right, let's go to the next slide. Thank you for your comments. So what is prognostication? And so it basically is to predict with a high level of certainty that a particular outcome will occur. And I grabbed this screenshot here from this artist, Pantia, who you can see on the left side, a young woman figure, and on the right side at the very bottom right, a skull figure or death with the sickle. And so there's always this juxtaposition between what our future holds in terms of lifespan, and that's one of the things that we don't want to dwell on. But quite honestly, a lot of people don't think about it. And particularly as they get older, they just don't think about it. And they may have expectations that are beyond the reality of what their remaining life years are in store for them. So we do have to ask the question. Okay, so we go to the next slide. So some of the questions that come up with prognostication are how far do we have to live? And the other question is, how much time do you have for a significant functional decline where you become dependent? So a lot of times people and older adults don't really think of that. It says, they'll say, oh, I don't want to be a burden to my children. But then they'll also say, I don't want to leave the home. I don't want to go to a nursing home. Well, how do you reconcile that? And what is your plan? And as you look at the economics these days, most people have barely $500 in their savings account. That'll give you about a half a day of healthcare, and maybe not even that. So clearly there are some points of view that we need to reconcile in terms of coming to terms with what the future may hold, and how do you prepare for that. So that's basically 2 considerations as to why it's important to prognosticate and come up with some information for the older adult to think about seriously in their life planning process. Okay, next slide, please. So this is a great Winslow Homer painting of 2 sisters looking off into the storm, where boats are coming off and the uncertainty of the storm. And so is life. We just have this uncertainty about what may come our way. And that's why it's important from an informed point of view and using research and life tables from the Center for Disease Control and so forth to really help inform the older adult about how to set goals. And then to share this, not only with this information with the provider, but also to share it with the family members. There was, I don't think I have it in this particular presentation, but older adults and family members tend to overestimate their remaining life expectancy, even in face of cancer. So if they say, oh, you have stage 4 terminal cancer, a lot of times when they do a survey of these people, they think they have 10 to 15 years to live, and when in fact they only have 1 to 2 years of remaining life expectancy. So there's a real disconnect between what people understand and what reality is. And so a lot of times the providers have to initiate a conversation that can help ground the older adult into understanding a little bit more realistically, as to what their lifespan may be, so they can better prepare for that. And that includes preparing for functional declines. The statement, I want to stay at home at all costs, may mean a lot of cost. If you need to help somebody to the washroom or to prepare meals for them, people don't think about that. They always think that everything's going to be great. I'm totally independent. I can take care of myself. When in fact, over half of the people are going to need, as we get older, half the population is going to need some form of nursing home care. Okay, next slide. So as we develop our skills, for prognostication, we have to understand the factors that will mitigate or impact the average life expectancy. So when we say that the average life expectancy for an American female is 81 years of age and for the American male is 78, what are the things that are going to make that person live longer than that average, or what things are going to be, moving towards a shorter lifespan? So as we prognosticate, it's important to have an effective communication of what your observation is, and also to make sure that the older adults and their families members don't really see you as being, the naysayer, but in some way, to invite them and communicate with them about what the future may hold. And it's important also to really stress the value of any type of medical intervention versus the futility of either a diagnostic or therapeutic intervention. So this happens all the time. Somebody comes into my clinic and they say, I need a head scan, I need a CAT scan. And you're thinking like, well, okay. Or they may even say, I need a total body scan. This is the big new controversy. And so the first question I asked is, well, fine, what are you looking for? And I said, well, I might have cancer. I said, okay, well, would you go to surgery if you had cancer? And they go, well, they have to think about it. And I said, well, that's something you should think about first before you start unearthing these things, because a lot of times you end up seeing what's, there's a medical term called the incidentaloma. So a lot of times when you see a tumor, it's like an adenoma, or it's a nephroma or something like that. It's a lump that you see on the scan, and 9 times out of 10 it's benign, but it puts you through a procedure, and procedures have side effects. And so again, you have to be careful what you wish for if you were proposing to have a total body scan, because if they find something, then it may lead to a biopsy. The biopsy may lead to complications such as infections and premature death. So again, trying to balance the potential value versus the potential futility of going that avenue. That comes into play with prognostic skills. Next slide, please. So the prognosis can really make a difference on how and the impact for healthcare decisions. One example would be providing life-sustaining treatments when there really is no hope. I mean, it's very clear that within days to weeks, maybe months, the individual is going to succumb to their illness. I had a prime example of a patient who came in. It was fairly young. He was 73-ish. I don't remember the exact age, and he was seen by a medical student, and it was a teaching moment because the medical student kind of missed that there were some cranial nerve findings. His eyes were deviated. He had lost a sense of smell, and he had a little bit of facial droop. And so I pointed it out to the medical student, but I said, we need an emergency scan, an MRI scan of the head, because I thought he had, some tumor that was encroaching on his cranial nerves. And in fact, he did. And in his case, he decided not to have any intervention because the likelihood of reversing the cancer was like less than 10% chance, and so he went a palliative route, and he was within 2 weeks passed on. So the opposite for that would be somebody who didn't recognize the futility of that particular cancer and said, I want everything done, and still there's no hope. So you have to be able to help distinguish that between different individuals who have different, perhaps, understandings of their prognosis. Another thing that we do is we discontinue cancer screening at certain ages. So, for example, Pap smears are not done after the age of 65 unless the individual is sexually active with multiple partners. So there's some caveats. But basically, the screening is not going to demonstrate any additional precancerous state. So then that becomes futile. Conversely, breast cancer screening continues for as long as necessary to match the independence or the functional independence of the older woman. So if you have, typically after the age of 75, we don't advocate breast cancer screening. However, if they are 80 years old and look like they're 70 and they're highly functional, then yeah, we probably would advocate, if in agreement with the patient, to do cancer screening, breast cancer screening. Okay, next slide, please. So a lot of times we have to use data to help reinforce our concepts of whether somebody, may survive. So, for example, when people come into a VA hospital, and if they're asked, do you want a full code or do you want CPR? Part of the information that would be shared with them is that several studies show less than 1% survival. If you have a cardiac arrest in a VA hospital, and actually other hospitals too, you have a very low chance of survival. So, kind of what's the point of doing CPR, particularly if you're going to be on a ventilator and all the bad things, and you go to the intensive care unit and have a very painful and prolonged death. So by providing this information in this particular case, you had at least half of the patients who wanted CPR saying that they no longer wanted CPR, given the data about survivability of CPR. So again, this is important information to share with patients so they can have really an informed decision-making potential rather than just say, yeah, I want everything done. Well, a lot of 99% of the chance you're not going to make it, and of those that do make it, they have a very miserable end, and they don't leave the hospital. Okay, next slide. So the idea of a prognosis coming up is going to be triggered by observations by clinical providers who believe that the individual has less than 6 months of life expectancy. And then in another case, as I mentioned, we would suspend health screening measures if we think the person has less than 5 years of remaining life expectancy. So these are some of the parameters that we use to guide some of our interventions or diagnostics. Next slide, please. So when we talk about provider-patient discussions, they really do go beyond just talking about life expectancy. We need to have a discussion about their functional recovery. We need to have a conversation about the duration by which they're going to be able to be independent or not. And then we also have to have a discussion as to what's most important to them. So for some people, it's having a attendance at a family member's wedding. So I kind of added Henry Rousseau's matrimony painting. Usually he has animals hiding in the trees, and I don't see any in this particular painting. But for me, what strikes me about this painting is that the bride seems to be floating. Everybody else in black seems to be grounded. So I'm not sure if that's just my illusion or what, from this particular painting. But in any event, it just reemphasizes the concept that people have particular anniversaries or dates or objectives that they want to accomplish before they pass away. Next slide. So an important concept when we prognosticate is to really think about the lag time of any intervention that you're going to provide. So the question is, will the intervention improve the quality of life, and for how long? Conversely, would the intervention cause harm? Some of you may be familiar with the Winslow Homer painting here. And I don't know if you know the history of this one, but he originally painted it with no boat in the upper left-hand corner there. There was, you can see there's a faint sailboat through the rough ocean. And when he had the art showing of this particular painting, people were really upset because they said there was no hope. Nobody was going to rescue this guy. And so he took it under advisement and painted the boat in the background with the perhaps the illusion that somebody would come to this guy's rescue. Of course, the sharks look like they're not going to make that happen. But in any event, so that's the whole question of false hope, and that's the reason I put this particular painting reference in there. Okay, next slide, please. So some of the barriers to diagnosis is that the providers themselves may have a discomfort. They don't want to be the messenger of doom and death, and it's so they avoid the topic, either because maybe it takes a little too much time in their clinic visit, or like I say, they don't want to be the Dr. Doom. The other one is patient avoidance. And so I've had encounters where people don't want to provoke the death spirit, just by talking about it. You never know what might happen. There might be some just resentment, it's like, who do you think you are? Where the patient thinks that you're playing God. And then others just don't want to think about it because what'll happen will happen. It's God's will, and there's nothing medically that you can do to change that. So again, it's a belief system that you have to at least understand, appreciate, and respond to. Next slide, please. So there's different ways to estimate prognosis. You can use your clinical judgment. You can use age-based life expectancy tables such as the CDC. It's called vital statistics. Or you can look at published studies. And so, for example, there might be a study on 2,000 patients that had breast cancer, and their survival rate showed the following. So those would be published studies. And then prognostic indices. So these are formalized tables. You put in numbers, different demographics, and it spits out a number and says likelihood of survival is X%. Okay, next slide, please. So in terms when we talk about clinical judgment, a lot of it really requires experience, and so we're always clouded by our experiences. But we also need to understand how a patient's going to respond, or perhaps not respond to certain therapies. And that's true in whether it be cancer therapy or chronic disease or diabetes. Some people just don't want to take insulin, so the question is, does that marginally controlled sugar accelerate their aging process and their death? And the answer is probably yes. And the other part with the clinical judgment is that, again, doctors don't want to be, and providers, primary care providers don't want to be the purveyor of bad news. We always want to give hope and try and give optimism. And I share with you an experience I had, which when I was first a geriatric fellow at Duke in North Carolina, I was seeing patients in a local nursing home, and there was a famous jazz pianist who was one of my patients. And I was going through his chart, and I noticed that he had been diagnosed with stage 4 cancer, colon cancer. And I asked him if anybody had discussed that with him and what his wishes were. And apparently nobody had discussed it with him. And when he heard that he had colon cancer, he went into a deep slide, a deep depression slide, stopped eating, and died very quickly within a week. So sometimes people's responses to bad news can be catastrophic. So I just kind of share that with, again, clinical judgment is often driven by clinical experiences. Next slide, please. So if we look at age-based life expectancy, there are tables for average, and they actually, I'll show you how it's broken down into quintiles, so you can have an upper or a lower quintile based upon other mitigating considerations. Because there's a lot of heterogeneity. Some people are going to have a shorter lifespan, and some people are going to have a longer lifespan based upon either family history, lifestyle, and trauma, any number of things. So let's see the next slide. I think that has the quartile tables. Yeah, there you go. So you can see that somebody who's age 80 there on the top row, that their highest expectation would that person could live almost 27 more years. So that you're talking about somebody living to 87. Whereas if they're in general poor health, not taking care of themselves, bad life habits, they're smoking, the likelihood of their making it to 74 is more likely. So that's the lower quartile. So these are the life tables that you sort of evaluate and make a guesstimate as to how much remaining life expectancy. Of course, the middle of the population, the middle of the road, will be 21.2 extra years at the age of 60. So that brings somebody up to 81, which is, again, the average life expectancy. But you can see as you go down the table to the left there, you've got a 95-year-old who, really robust 95-year-old could live another 5 years approximately. Whereas if they're frail and decrepit, they probably have only maybe 1.5 years of remaining life expectancy. And you can see that these numbers, if you just do a rough comparison, they're different for men and women. So unfortunately, men don't have as good prognosis for their lifespan. And that's a whole different presentation perhaps. But you can just see, even under the 95-year-old row, that the life expectancy in the 25th, or the low quartile, is 1.2 years versus 1 year for men, women versus men. Okay, let's have the next. So you can also try to refer to published studies. I mentioned, like, a cancer study. So survival from, cancer studies is good. The only problem is that, when they talk about survival, it's like usually 50 to 60-year-olds. They don't talk about survival of 75 to 85-year-olds. So you're a little bit limited in giving advice as to how many remaining years of life. In fact, you may give somebody false information if you say, well, this study showed that, people lived 8 years longer after the particular therapy. Well, if you're 90 years old, you're not going to be living eight more years, because your average life expectancy is already down to 4, right? So you can't have more life expectancy because you got chemotherapy. So if that makes sense. Okay, next slide, please. some of the prognostic indicators or indices we use these clinically. So for example, what is the risk for skin pressure ulcer? So we use the Braden scale. What's the risk of falling? We can use the Berg scale. What's the lifespan of a systolic heart failure patient? We use the Seattle Heart Failure Index. And so you can refer to these on a website from University of California. It's called ePrognosis, and there's a whole collection of tools that can help you, punch in some numbers and come up with some ideas as to how your particular patient, what their survival may be. Okay, next slide. Yeah, so just some specific examples is in dementia, we use the FAST scale, the functional assessment scale. And if they score 7A or greater, then they are eligible for hospice care. There's another tool called the ADEPT, which also helps with prognosis, because a lot of times people will say, oh, okay, so my wife or my mother has Alzheimer's, how long does she have? And so these tools can help guide you. But basically, we know, as a rule of thumb, that once the diagnosis of Alzheimer's is made, the remaining life expectancy is about 10 to 12 years. If they have cogwheeling or look like they have Parkinson's-like symptoms, you reduce that by 2 to 3 years. And so their life expectancy is less. Next slide. In terms of cancer, it's a tough one because, it's a moving target. There's new therapies coming out all the time. The operative word is what I mentioned earlier, is that when you look at these prognostic indicators from cancer studies, excuse me, the question is, did they do the study on a 75-year-old? Did they do it on an 80-year-old? So you need to kind of relate to the patient as to what the study population age range was. One thing that's true is that the functional status really predicts prognosis. And so that's true of normal aging without cancer or with cancer. The people that have poor functionality, they need assistance with grooming, bathing, transfer, walking. All these disabilities or functional disabilities are reduce their life expectancy, is the bottom line. Next slide, please. So with heart failure, I had mentioned the Seattle Heart Failure Model. There's another one called EFFECT. So these you can look up. You can Google them, and they'll take you to the sites, and you can use those. One of the things that may make sense, but is in the research, it shows that the number of times that you end up in the hospital for heart failure and or loss of functional status, that you need assistance with your ADLs, that those are highly predictive of death. So I often tell people that if they're in their second or third hospitalization for heart failure, it'd be best that they get their advanced care directives settled and all their family affairs settled. Next slide, please. For COPD, I have not used this, but it's called the Bode Index. It's basically, usually we use FEV1 as a measure, for advanced COPD. But this Bode Index is a collection of measurements that can help predict remaining life expectancy for the COPD patient. Okay, next slide. In terms of end-stage renal disease, it's important to realize that once you go on dialysis, that you have a low survival rate. And so I had a colleague who was head of nephrology back at University of Illinois, and he says that basically from his point of view, that once you go into dialysis, you're not going to live past 6 years. And this data basically helps reinforce that concept that dialysis is really a limited lifespan. If you happen to be in a nursing home and you're getting dialysis, you probably have about half of all these numbers that we see here for the community dwelling older adults. Okay, next slide, please. So what the caveats that we need to be careful of is that a lot of the data that we get, we can't really compare from community dwelling to nursing home older adults. People who are in nursing homes tend to have a much shorter lifespan because of their loss of functionality. We don't always know for sure how race and gender affects these indices. Sometimes these indices are just very global, and we don't always know if the female versus the male longevity preference holds up when there's things like cancer, for example. And then we don't also know how much wealth. We know that wealth contributes to a longer lifespan. So the richer people tend to live longer, which is probably some of there's, no worries associated with social determinants of health. So food and socialization and free and safety and all those factors. So anyways, those are some of the caveats where we haven't really been able to make credible adjustments in estimating life expectancy without knowing more about these other determining factors. Next slide, please. So when we talk about communicating the prognosis, we want to make sure that the patient understands, is ready, and also figuring out what their expectations are, and then to a certain extent try to understand their emotional IQ, how much self-awareness do they have. Next slide. So we can use the spikes mnemonic for delivering bad news. It's a 6-step process. Next slide. So we want to know the setting. So it should be in a comfortable setting, one that's not where you're not going to be interrupted. We want to ask people what they think. What do you think's going on? So that's perception. And then an invitation. Is it okay that we talk a little bit more about, what's going on? And then there's an exchange of knowledge. What do you know? This is what we know. This is, some of the research and so forth. These are the clinical data. And then you want to explore the emotions. Try to maintain eye contact. Honest to gosh, when I'm in the clinic, my computer is set so that I have to be at a 90 degree of the patient. So I got to get off the computer, turn myself, and face the patient to make eye contact. And then finally, as part of spikes, is to summarize the information. You can also have the patient give you teach feedback as to what their understanding is. Okay, next slide, please. So I want to move from the individual to now population health and just talk about a few things about prognosis and through the population. So if we can have the next slide. So this is an important concept. I may have made this previously where we talk about the absolute lifespan on the right and then what we call the functional lifespan on the left. And this is not maybe the best graph to illustrate this, but basically the gap between the blue line and the orange line is about 2 to 3 years. And so when people start to functionally decline, it's usually a good indicator that they're on their way to meet their maker. And so I think that's why in geriatrics we always do functional status or functional measurements, because like if people need assistance with bathing, grooming, dressing, feeding, transfer, that's usually an indicator that their lifespan is going to be quite a bit shorter. And so that's why there's a relationship between functional lifespan and absolute lifespan. For those that are interested, I'm collaborating with a researcher from North Dakota State University, where we're looking at grip strength as a predictor of mortality. So, again, a decline in grip strength is tightly associated with your lifespan. Excuse me. And so we can use these different functional assessments to help inform older adults about their remaining life expectancy. Next slide, please. Yeah, and this just reemphasizes the fact that there's a 50-50 split between people who are older than their actual biologic age, or chronologic age, I meant, versus their chronologic age. So if you take a particular group of people, like in this case, 38-year-olds, you can find half of them are older by up to 5 to 7 years older. And then there are people that are younger by about 7 to 8 years. And so it's kind of interesting, that there's this distribution of people. And so we have to keep that in mind, that even though we're talking about average numbers, there are some people who are going to have accelerated aging, and there are some people that are going to have much slower aging. And believe it or not, just by looking at somebody's face can help guide you as to whether you think they're older or younger than their actual stated age. Next slide, please. So to help improve the prognosis, there's different things that we can talk about for the population health here. We can talk about food as medicine. We can talk about a mobility plan, so that's part of the 4 M's. We can also talk about socialization and belonging, and also having a sense of purpose. All of these features play into healthy lifespans. And if you have a chance to maybe talk a little bit about the Blue Zones project, you can look and see. It's actually on Netflix. They have a whole series now on Blue Zones that talk about the ingredients that researchers think go into people becoming 100-year-olds in a very highly functional way. Next slide, please. So just to summarize, and we can take some questions, is that we want to engage the older adult with what matters most to them, and to do so in the context of how many years of remaining life expectancy they have. We can do that and promote that conversation through lifespan tables. They're called the vital statistics from CDC, or you can just even go to my slide deck here and pull out that chart if you want a pocket chart. Just fold it up and keep that handy. You can go online to the e-prognosis to look at chronic disease indices. You can also use the spike mnemonic for conveying bad news. And then ultimately, from a population health perspective, we want to champion healthy lifespans by emphasizing the positive things that you can do, such as eating right, staying mobile, socializing, and reducing stress. And so a lot of things that are advocated in the Blue Zones, the 9 pillars that the Blue Zones talks about, are pretty much proven ways that populations of people live longer than the average. So those are important considerations.